Hello, welcome to Vernon Integrated Medical Group. My name is Dr. John Trister. I practice internal medicine, orthopedic medicine, and prolotherapy.
My name is Dr. Diana Trister. I practice osteopathic family medicine, sports medicine, and prolotherapy.
Lecture number 1, cervical spine, evaluation and treatment. This is Michael. He will serve as a model today. Treatment of the cervical spine we perform in a prone position using these wedges which enable us to produce maximal flexion of the head, and this optimize palpation of the cervical spine structures and make treatment safe. In our practice, we use standard 15% of dextrose for extra-articular injections and 25% for intra-articular injections. I use 60 cc syringes and I prepare every morning enough syringes which will be 15% of dextrose, and I put them in a special stand, and each syringe will be served for one patient. Sometimes patients need more than one syringe, so we'll not share the syringes among different patients. So the next syringe, it will be a syringe for local anesthesia. We make about 0.5% lidocaine mixture and add sodium bicarb. And this is the syringes is what we use for injection, 10 cc syringes, and we use various needles. This is a typical spinal needle for most of the lumbar injection, and red needle, 25 gauge needle for neck and ribs injections. Skin preparation, we use iodine and alcohol, and we have the basins like that. They sterilize in a sterilizing machine, and we put here gauzes, iodine and alcohol, and make a preparation of the skin prior to injection. Brief anatomy relevant to orthopedic medicine and prolotherapy. Cervical spine can be subdivided by 3 major regions. First is the occiput, and you can see occiput here. Upper cervical spine, which consists of C1 and C2, axis and atlant, and lower cervical spine, which will be C3, C4, C5, C6, C7. C1 and C2 spine, they are unique in anatomy and function. C1 attached to the occipital condyle and connect skull to the cervical spine. And axis is the second spine, and atlant sitting on the axis, and rotation of the head, about 45 degrees of rotation occurs in the atlantoaxial joint. Atlantoaxial joint. Another 45 degrees of rotation occurs combined motion of the between C3, C4, C5, C6, and C7. The flexion and extension of the head occurs between C1 and occiput. Rotation between C1 and C2, lateral flexion occurs in the lower cervical spines. On the skull, there is several important lines which I want to demonstrate. One is called inferior nuchal line, the site of attachment of the muscles. Superior nuchal line, which is site of attachment superficial muscles. And protuberantia occipitalis externa, or inion, which is the site of the origin of ligamental nuchae. There is a multiple muscles which attach to the base of the skull, and you can see them on this model, and it will include posterior occipital minor, which connect to inferior nuchal line and C1, posterior occipital major, inferior nuchal line to C2 spinous processes, obliquous superior and obliquous inferior, which connect to the transfer processes of the C1, right here. And then will be a semispinalis muscle, semispinalis capitis, splenius capitis, trapezius, and sternocleidomastoid, and they're attached to the different portion of the skull. Specifically, sternocleidomastoid muscle attached to the mastoid process, and trapezius muscle attached to the space between inferior nuchal line and superior nuchal line, and partially originate from the ligamentum nuchae. This is one important opening on the base of the skull, and I will demonstrate this to you, and it's called jugular foramina. The jugular foramina, this is foramen, it's made from two incisures. One incisurus formed by temporal bone, and another incisurus formed by occipital bone. Together, they form jugular foramina. Through the jugular foramina, very important anatomical structure passes from the cavity of the brain. Nervus accessorius, nervus glossopharyngeus, nervus vagus, and jugular vein. They are very important because they could be disturbed during prolotherapy treatment and cause various of symptoms which can be very disturbing for patient. Proximal to trapezius muscle, there is occipitofrontalis muscle, which consists of two muscular groups. One is occipital and another is a frontal, and between them aponeurotic complex. Together they call halio-aponeurotic complex, through which complex multiple branches of the greater occipital nerve pass, which are responsible for various symptoms related to headaches, cervicogenic headaches, occipital neuralgia, muscular tension. This is occipital triangle. There is multiple arteries, veins, and nerves coming, and this is not the area for injection. This is spinous process of the C2. This is spinous process of C3, C4, C5, C6, C7. C7 is the last vertebral cervical spine which rotates during head rotation. T1 already not rotating. This is how to differentiate between C7 and T1. Besides that, you can see other structures. You will see laminas. This is very important structures in the cervical spine, laminas. And facet joints right here, facet joints. And this is our targets for injections. In addition to this, you see interspinous muscles, tiny interspinous muscles, which are responsible to create a tension of the ligaments, interspinous ligament and supraspinous ligaments, which create global stability of the cervical spine. Supraspinous ligaments, interspinous ligament, and interspinous muscles in a constant communication between each other because of proprioceptors transmitted from the ligamental structures transmitted to muscles and regulate muscle tone, and in the same time muscle tone regulate tension of the ligaments. Examination of the cervical spine region include evaluation of the posture, position of the head, function and range of motion of the head, rotation to the right, rotation to the left, flexion, extension, position of the arms, fingers front, and to see the length of the arms. And you can see in this case, right arm is slightly longer than left, which indicate rotoscoliosis. We use variety of instruments to document our findings, such as inclinometer for flexion and extension, lateral bending, this inclinometer for rotation, and this T-square for evaluation of the equality of the shoulders. Examination of the cervical spine also include neurological examination as well as all general clinical examination. If we find any neurological abnormalities, asymmetry of reflexes or sensitivity, it will be indications for more detailed imaging studies like an MRI. For all patients who come for cervical spine treatment as a result of previous injuries or strain or chronic pain, we do always x-rays of the cervical spine, at least in the 6 positions. Flattening of the cervical spine on the lateral view indicate muscle spasms of the posterior muscle. Surface anatomy for clinical examination. We must identify several structures which potentially could be painful. The first, we locate the protuberantia occipitalis externa or inion. This is right here. This is again site of attachment of the nuchal ligament. Then you glide your thumb down, and the first palpable tubercle, it will be spinous process of the C2. Spinous process of the C2 is a part of the bone, and there is multiple connection, which I will talk about this later. Then go C3, C3, C4, C5, C6, C7, and T1. Now I will ask Michael to turn your head to the left. And I see that C7 is moving. Now turn your head to the right. C7 is moving. Now I put for next spinous processes, please turn your head to the left. It's not moving anymore. So the first non-movable spinous processes will be T1. The last movable spinous processes will be C7. When palpating and marking points for injection, we need to identify inion, which is protuberans occipitalis externa. Then we glide our finger down until we palpate the first palpable spinous processes. It will be C2 spinous processes, and I mark these C2 spinous processes. C2 is very important because this is the place where multiple muscles and ligaments connect the cervical spine to the skull. And this will be C2. Michael in the past had multiple injuries. He is a professional athlete and he had multiple injuries of the cervical spine. So for that reason, his spinous processes, which I mark now, are not very symmetrical like we expect in a typical healthy individual. So we mark spinous processes. So this is his spinous processes C2, C3, C4, C5, C6, C7, T1. And this is interspinal spaces here and here and here and here and here. Then you need to identify laminas, and laminas will be approximately 1 finger breadth from the midline, or splenius capitis. This is a muscle which you palpate the groove here, just lateral to the midline. This is the groove which will correspond the facet joint and lamina, and you will put a line corresponding this area on both sides. Then another finger breadth lateral, it will be area of the facet joints, and you will mark area of the facet joints. When this is ready, and then you select the syringe with the local anesthetic. We use 30 gauge needle for this purpose, and we do injection of the lateral rows first, and then on the end midline row, in order to ability to palpate the spinous processes. So I usually do this. Some people do injection of midline first. It's not principally important, but I start with the area of the laminas, facet, lamina, facet, and then on the end I will inject midline. I never forget to inject protuberans occipitalis externa, because here is the area of the starting point for ligamentum nuchae, which create the major stabilizing factor, major stability for entire cervical spine. In addition to this, from ligamentum nuchae, part of the fibers of the trapezius muscle on the right and on the left also started. So injecting ligamentum nuchae in the protuberans occipitalis externa stabilize very nicely cervical spine. Then we must also identify the superior and inferior nuchae line. And superior nuchae line will be on the area of the inion, and you provide, this is superior nuchae line with attachment of the trapezius and sternocleidomastoid muscles, and inferior nuchae line, which are deep muscles attached here. And then when you do injection of this area, your needle must be almost tangential to the skin or perpendicular to the skull in each particular area. So if you inject here, your needle go away from the foramen occipitalis magnum, and you redirect angle to this point here. The same here. You not inject toward the foramen occipitalis magnum, you inject laterally, and needle must be perpendicular to the skull in each area of the injections. Then you take solution of the 15% of dextrose, and we use the 60 cc syringes, and we hold this in a special holder, and we prepare this solution for this specific patient. This already has a solution of 15% of dextrose, and we use 25 gauge needle, and we inject the injection to the lamina first, and then to the facet joints. Direction of the needle should be 45 degrees caudate and approximately the same toward midline. The needle must touch the bone. If your needle does not touch the bone on expected depth, you're in the wrong place. You must pull back needle, slightly reposition it, and re-inject again until you reach the bone. Do not inject if you do not touch the bone. And you continue to do this down, down. In each individual area, you inject laminas here and here and here and here. I always include a little few upper thoracic spine, T1 and T2, to the treatment. Then you go to the area of the facet joint, the same, approximately the same direction. You do caudate 45 degrees into midline about 45 or 35 degrees until you reach the bone. You reach the bone, you inject. Reach the bone, you inject. My recommendation is to hold your syringe in such a way that when you touch the bone, you're ready to inject. Sometimes I see people using syringe like this, and they put a needle and they touch the bone, and then they start to manipulate and reposition the hands, which create dangerous situation for the patient. If you inject this way, it's fine. You're ready to inject, or you inject this way, it's fine. But make sure that when you hold syringe, your hand is ready to inject as soon as needle touch the bone.
What about changing needles frequently?
Good point. After 4 levels, 2-3 usually levels of injection, the needle become dull, and I always change the needle, and I take another needle, because the sharper the needle, the more accurate injection. Thank you. So when we finish one side, we switch to another side and do the same here. Injection of the laminas, the same 45 degrees, and touch the bone and the facet area as well. Always touch the bone. If you don't find the bone on the depth you expected, you're in the wrong place, reposition needles. Don't rush. Then you start to do injection of the spinous processes. And here you will inject, the most important in my point, is the C2 spinous processes. You inject C2, slightly caudate direction. It's easy to identify even in overweight people, and you inject C2. Injection of the C2 will achieve stabilization procedure, stabilization process in the multiple other areas of the spine. So C2 is very important. Then you do C2, then you do supraspinous and interspinous ligament between C2, C3, C3, C4, C5, C6, and your needle almost go tangential to the skin, like that. Not like that. Sometimes you can end into the spinal canal. Just the more tangential you are to the skin, the more safer and more effective treatment.
How many cc's do you inject at once?
0.5, 0.25, 0.5 cc, no more than that. And then injection of the nuclear lines, again, as I mentioned before, you inject away from the foramen occipitalis magnum, you inject half cc, half cc, half cc, half, and you change direction of your syringe. You can do this way, or you can do this way too. And inferior nuclear line as well. So when you inject inferior nuclear line, don't do that. You must go like that, almost parallel to the skin, almost tangential to the skin. This will assure that you will be exactly on the skull during this procedure. As I mentioned before, here is a transition from one bone, temporal bone, and specifically mastoid process, which is a part of the temporal bone, to occiput. And here also two different muscles attached. On the mastoid process is attachment of the sternocleidomastoid muscles. On an occipital bone is attachment of the trapezius muscles. When we inject solutions, when we inject prolotherapy, it generates tensile forces which may affect tension, which may cause interosseous and intraosseous sprain in this area, which will affect jugular foramina, what I mentioned before. Especially this is true for those people who have hypermobility syndrome, and they may experience various of symptoms such as dizziness, headaches, palpitations, and we must alert them about this possibility to take it easy for first 3 to 7 days after the procedure. Sometimes I observe this side effect on the day number 10 and 14, and Diana sees this more frequently earlier a little bit. So just be careful, and please tell patients that this injection on the occiput may cause temporary side effect, which are not dangerous, but they must know about this, alert them about this. One more thing, it's very important that the patient who comes for treatment will have dedicated driver. He cannot drive home by himself because his neck will be stiff, and this is safety reason. And we prefer to do this injection on the Fridays, so patient will have day off on Saturday and Sunday. Another safety precaution for those people who have hypermobility syndrome may develop hypotension and vasovagal symptoms. We prefer to give 50 milligrams of ephedrine IM 20-25 minutes prior to procedure and establish IV line just in the case if we need to make an infusion. Thoracic spine. Thoracic spine has 12 vertebrae. This is less mobile compared to cervical spine and lumbar spine because of presence of the ribs. But the structure of the spine basically very similar. They have spinous processes, they have arches, they have facet joints, they have transverse processes which are very prominent, and they have a connection of the transverse processes with the ribs. The interspinous ligaments which present in the thoracic spine are very powerful, and there is a continuum of the ligamentum nuchae just only on the thoracic area spine. Again, this is less mobile portion of the spine, but as we get older, it has a tendency to develop kyphotic deformity, and kyphotic deformity leads to various changes in the spine. And one of the first changes you will see forward head posture, and people develop thoracic kyphosis. As a result of thoracic kyphosis, you will see sometimes subluxation of the sternoclavicular joints, both left and right, sometimes one more prominent than in another more prominent. Another features of the development of the kyphosis will be changes in the voice, because all anatomical apparatus and larynx and pharynx they are attached through the fascial layers to the spine, and any changes and alteration of the form of the thoracic spine will lead to changes in the voice. The vertebral bodies of the thoracic spine goes from smaller size on the upper portion to larger size in the lower portion. Lower portion spine, thoracic spine, is T12 or sometimes T11, which is called transitional vertebra. Transitional vertebra characterize that his superior facets looks like thoracic spine with the frontal direction of the zygoapophyseal joints, but lower facets looks like a lumbar spine with the sagittal direction of the facets. So this makes this spine, this vertebral spine, transitional spine, usually T12, more vulnerable than other vertebrae. Ribs. Ribs has basically 4 points of connection in the body. The first point of connection in the body is called costovertebral junction. This is between vertebral body and the rib, head of the rib. This is costovertebral junction. Those areas are not for prolotherapy. They're too deep. Second place where ribs connect to the vertebral body, it will be transfer processes. It's called costotransfer junction, costotransfer joint. There is a powerful ligaments here. Then ribs will rotate this forward and we will see a costochondral junction when ribs become initially like a bone and they connect to chondro or cartilaginous portion of the ribs. It's called costochondral junction. And then we'll see chondrosternal junction, the junction between cartilaginous portion of the ribs and the sternum. So this arrangement, this architectural design is very important because ribs must perform not only protective function to protect heart and lungs, but they also participate in the motion of the diaphragm. They generate forces which enable lungs to expand, which enable pericardium to work properly, and ability to have this cartilaginous portion of the ribs enable ribs to be more flexible. They may do torsion and various changes in the form which make work of the diaphragm and muscles connecting ribs more efficient. Scapula, one of the portion of the thoracic spine and ribs, and scapula is suspended on several muscles which hold scapula in a position over the chest wall. The only true connection of the scapula is acromioclavicular joint. This is the only place where scapula directly connect to the bone. Other places the scapula is suspended between action of different muscles. One of the muscles called levator scapular muscle, which attached to the medial border of the scapula. On this distal attachment and proximal attachment, there's a transfer process of the 2, 3, and 4 cervical spine. The levator scapula technically is continuity of the supraspinatus muscle, because supraspinatus muscle ends on the area of the medial angle of the scapula, and here is the started levator scapula. This is a postural muscle, and every time when we have postural abnormalities, the muscles start to act. And when you see the patient with the pain in the levator scapular muscle, always suspect an enthesopathy will be the consequences of attempt of the body to correct the postural abnormality. When we perform injection of the thoracic spine, the technique basically the same. We put 1 finger breadth lateral to the spinous processes, 1 finger breadth lateral to the spinous processes, and it will be area of the laminas. And slightly lateral to this, you may consider to inject costotransfer junction. These junctions is very important because they determine how ribs will rotate and how ribs will perform and affect the function of the diaphragm. So injection of these joints should be done in the tangential direction like this. Then risk to penetrate the lungs much less than when you do injection in the vertical way to do that. Some physicians recommend to start with the lateral point to locate this angle of the rib, which is very prominent, especially in skinny individuals, and you can palpate the ribs and you can use the needle and inject very gently this area. Again, know your depth and do not go beyond anticipated depth of the ribs, otherwise you will be in the pleural space and you may penetrate the lungs. I use one of the techniques which make less risky to do penetration of the lungs. I ask patient to take a deep breath, then exhale, the volume of the lungs is reduced, and during the exhalation, which patient can tolerate about 8 seconds, I inject the ribs, then I remove the needle and ask patient, now you can take a breath. People do several inhalation, exhalation, exhalation, inhalation, then I ask them, please exhale air and hold for 10 seconds, and I continue to do injection of the ribs. So this is on all areas of the ribs. This is one of the safety precautions. So we discuss how to inject laminas. We discuss how to inject the costotransverse junctions. Now, how to inject interspinous ligaments. This is extremely safe injections, and you go again in the caudal direction. Use needle 25 gauge, in most cases is enough, red needle, and you inject the supraspinous processes and interspinous processes. And sometimes for those people who do not feel uncomfortable to inject lateral portion of the thoracic spine, if they do just thoracic spine in the midline, they will bring a lot of relief of the pain which patient might have here. One of the frequent complaints among our patients is anterior chest wall pain. I start with the proximal area, specifically sternoclavicular joint. Sternoclavicular joint is very easy palpable and very superficial joint, and injection of the 15% of dextrose into this area provide a lot of relief if the patient has symptoms. Don't try to go deep into this area because behind the sternoclavicular joint is a vagus nerve. I don't try usually to inject the first rib on the sternum, on the manubrium sternum, because it's hidden by clavicle. But second rib and third and fourth, etc., they're easy palpable. And this is a very good treatment for costochondritis or Tietze syndrome. And you identify area of the costochondral junction and area of the chondrosternal junction. And you put again, like in the back, you put 2 fingers in the intercostal space, and you inject area of the connection of the costal portion to cartilaginous portion, between cartilaginous portion and the sternum. Again, here and here, here and here. Sometimes I simply inject ribs here and I continue in the chondral portion until I reach the sternum. This is very safe injections, especially if you put your 2 fingers between and you isolate your rib of interest by your 2 fingers and you not go inside the pericardial space and the mediastinum. So this is a very effective treatments. The same, a lot of people complains pain on this ribs portion, and you inject the same area, costochondral junction, costochondral junction, costochondral junction, and sometimes it's require injection all entire cartilaginous portion of the ribs here. This is here. Very often we see the pain which in the areas of connection of the obliquous abdominal muscles or obliquous internal muscles to the iliac crest. It's still continuity of the ribs, and this is usually manifestation of enthesopathy, which develop as a result of either antalgic scoliosis or scoliosis developed as a result of iatrogenic factors such as hip replacement or knee replacements. Examination of the thoracic spine and marking of the thoracic spine, this will do this. So using 2 fingers, we identify spinous processes of the thoracic spine, and I mark them. T1, T2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. This is 12 actually. And then 1 finger breath lateral to this line, it will be area of the laminas. And again here on the right side, 1 finger breath or will be lateral to this line. And so this is your area of injection. And again, direction of the injection will be caudate, 45 degrees down, 45 degrees down. So what I often do, I hold like this syringe and I inject here toward the lamina, then pull the needle back and inject strictly perpendicular in the caudate toward the facet. Again, lamina, facets, lamina, facets, lamina, facets, lamina, facets. When I go into opposite side, I usually stay here and I inject again lamina, facets, lamina, facets, lamina, facets. Again, needle must touch the bone. If needle didn't touch the bone on expected level, pull needle back, redirect needle. If you cannot find the bone, you will inject this next time. So you finish this injection up to the level T12, and then you inject interspinous ligaments and supraspinous ligaments in the midline. Very important injection of the scapula. And the scapular injection we put patient in a position with arm externally rotated and abducted. So he put this arm behind his waist, and you can use your body in order to protrude scapula. See how this become more visible, and this is not. So you do that, and then you isolate the medial angle of this scapula, and injection goes to this area right here. This is you palpate this medial angle, and this is attachment of the levator scapular muscle. This is levator scapular muscle. Here will be rhomboid minor, then rhomboid major here. And then underneath will be serratus anterior muscles. Examination, palpation, and injection of the ribs. The best to start to identify the ribs in the area of the ribs angle. So there is a most prominent rib right here. And I put my finger above the rib edge and another below the rib edge. So between my two fingers, there is a rib here, and I mark it here. And I walk my fingers this way, that way, that way, and that way, until I reach the costo-transfer junction. Then I'll ask Michael to do, please, Michael, take a deep breath, exhale, and hold. Don't breathe until I finish injection. So I inject, 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 gliding, gliding, gliding. Remove needle, take a breath. Out. Again, in, out. And hold. And again, inject here, and I walk my needle on the rib, remove the needle, take a breath. Out. So again, during injection, patient should not do any respiratory motion. Only when I inject needle, patient should not take a deep breath. Sometimes I ask patient before injection to do this training. I ask the patient, take a deep breath, exhale, and hold. 1, 2, 3, 4, 5, 6. Needle out, inhale. So we do a couple times this training to let patient know what he will anticipate during this procedure. So this is injection here. Now, Michael, would you be so kind to turn on the back? Very often people come with a complaint on the pain in the sternoclavicular joint, and I identify the area of the sternoclavicular joint and inject very superficially connection between sternum and clavicle. The second rib is second and third and fourth rib is a more frequent cause of the costochondritis or Tietze syndrome. And you identify the most painful area. You put your one finger above the rib, another finger below the rib, and you inject and inject the cartilaginous portion, sternum, and costal portion. Cartilaginous portion, sternal portion, and the rib portion. Here is not important coordination with respiration like we did on the posterior aspect of the back because there is no lungs here. This injection extremely safe and very, very, very effective. The next very frequent complaint, people come with xiphoid process pain. And in the area of xiphoid process, a connection to the corpus sternum and xiphoid process, you simply inject 15% of dextrose into this area. Exactly, will be very helpful. Don't forget to palpate adjusted cartilages. They're often very painful too. And inject these cartilages with the 15% of dextrose, both bilaterally. Okay, if necessarily, inject rib cage completely, rib cage here and here with 15% of dextrose. Very effective and very safe. Lumbar spine and back pain, one of the most frequent complaints which physicians see in their practices. We need to be able to identify those pathology which can be successfully treated with the prolotherapy. We should exclude possibility of cancer or inflammatory processes. Rheumatological conditions should be excluded from this category of patients. For this purpose, before starting treatment for lumbar sacral pain, I always check a laboratory tests like complete blood count, basic metabolic panel, sedimentation rate, and urine protein electrophoresis. And this is few very important tests which should be performed. In some cases, when you suspect a rheumatological condition, anti-nuclear antibody with cascade also will be important to do. Imaging study also very important. I start with a simple X-ray. If I suspect lumbosacral radiculopathy or suspect the possibility of spinal stenosis, then I'll do imaging testing in the form of MRI. I do not do much ultrasound because I was not trained to do diagnostic ultrasound. I do only ultrasound for needle aspiration and positioning. So for me, X-ray and especially standing X-ray, bare feet X-ray of the pelvis, hips, lumbar spine and thoracic spine is very important in addition to blood tests. So people present with pain, diffuse pain, and in the lumbosacral area from L1 to L5. Sometimes there is no such a borders, and they have thoracic spine as well pain. So we examine patient, look in the range of motion, lateral flexion and extension, check neurological examination to make sure that patient doesn't have neurological deficits. And again, laboratory test important. Then let me briefly go anatomy of the lumbar spine. When we talk about lumbar spine, we cannot just isolate 5 lumbar vertebrae. We must include junction with the thoracic area, with the sacrum, with the ilium. So starting from superior aspect, there is a transitional vertebra which is called T12, and inferior facet joints of T12 have a direction like lumbar area, but superior facets have a direction in a plane orientation like a thoracic spine, frontal. Here's the frontal, distal is the sagittal. So this unique vertebra called transitional vertebra has experienced much more mechanical stress than any other vertebrae because it's participating in many planes and in many directions. Next is a lumbar spine, and you will see here the spinous processes. We see laminas, right here, laminas. facet joints, laminas, spinal processes, supraspinal ligaments, interspinous ligaments. There are several muscles which attach to the spine, and this will be erector spinae muscles, right here. Multifidae muscles, which will be on a deep level of the area of the arches of the lumbar spine, and facet joints. Quadratus lumborum, more superficial muscles, and other muscles coming from the ribs, such as obliquus abdominis externus, obliquus abdominis internus, which attached also into this area. The sacrum is positioned between two ilias, and it's suspended between two ilias with the help of the ligaments. And this is a small model of the pelvis, and you can see the sacrum, you see ilium. In the normal position, the sacrum is suspended between two ilias. This is a system of suspension. And when we walk, the pelvis moves forward, it's called nutation. When we pelvis go back, it's called contornutation. So several muscles and ligaments in this area control nutation and control contornutation. Specifically, nutation is controlled by sacrotuberous ligament and biceps femoris from hamstring muscles, and contornutation is controlled by interosseous ligaments which are located between the sacrum and ilium. The goal of prolotherapy in this area, how to stabilize, how to rebuild and restore system of tensegrity, a system of pre-stress in this area which at some point was present in our system. So I always start to identify the injection from identifying L5 transfer process. This is L5 transfer process. It's located in a border of erector spinae muscles and iliac crest. When you find the edge, when the external border of the erector spinae muscle cross iliac crest, this will be area of injection of the transfer process of the L5. Then you do injection L4, L3, L2. And this is facet joints. The facet joints have meniscoids, small structures inside the joints which tighten, controlled by capsule of these joints. And this capsule is connected to multifidae muscles. So the proper function of the multifidae muscles will determine how facet joints will be able to tolerate mechanical stress. From transfer process of the L5 and L4 is going powerful ligament called iliolumbar ligament, which connect these two vertebral bodies to the anterior aspect of the iliac crest. So they actually attach here in front, right here they attach. So when we do need to stabilize this area, we need to inject exactly into the area where the iliolumbar ligament connect in front of the ilium, and transfer process of the L5 and L4. This ligament connected tightly inside to the quadratus lumborum. So any sprain of the iliolumbar ligament will be reflected on the tonus of the quadratus lumborum, and it go to spasm of the quadratus lumborum. If you have pain in the area of the quadratus lumborum and spasms, this is one of the indications that iliolumbar ligament is strained and needs to be treated. The transfer processes are really important because this is not only site of attachment of the ligaments, but also there is several muscles which work together with the spine and attach in this area. Specifically will be erector spinae muscles, number one, intertransversarii muscles which connect transfer processes between each other, and in the front it will be iliopsoas muscle. So all of these muscles are interconnected and connected to the transfer processes of the lumbar spine area. And on the opposite side, you will see quadratus lumborum. Targets of injection in the lumbar spine will be supraspinous ligaments, interspinous ligaments, arches, laminas, facet joints, transfer processes. In many cases, we need to inject iliac crest, superior edge of the iliac crest, if enthesopathy involved quadratus lumborum, or we'll inject proximal aspect of the ilium, whereas enthesopathy involved gluteus maximus and gluteus medius. Let's identify important points for lumbar sacral area, and I start with identification of the L5 transfer processes. So I palpate midline here, and I palpate iliac crest, and I palpate erector spinae muscle, and then I glide my index finger until the point, lowest point on the iliac crest, where is erector spinae muscle end. In other words, the edge of the erector spinae muscle, when it crosses iliac crest, is the point of injection into L5 transfer process. The next point will be slightly above, about 1 centimeter above, will be L4, L3, L2. Again, this is spinal processes, this is erector spinae muscle, this is edge of the muscle, and this is iliac crest. Where they cross this area, iliac crest and erector spinae muscle, this is the point of injection for L5 transfer process, which also is a site of attachment of the iliolumbar ligament and partially site of attachment of the quadratus lumborum muscle. And you inject under 45 degrees toward medial aspect, and you will touch L5 transfer process. When you on the L5 transfer process, then you can inject half cc, 1 cc of the solution, slightly pull back needle, redirect needle a little bit in a steeper way toward more medial aspect of the transfer process, and you walk your needle until you reach the facet joint, and you inject into the facet joint area as well here. So this is L5, and you walk all entire L5 transfer process from the end to the connection with the facet joint. Then you do the same with the L4 transfer processes. You inject here, and you walk your needle toward midline until you reach facet joint. You inject constantly, the same here, the same here. Why these points are very important? Because those points are also attachment of the thoracodorsal fascia, which surround all entire musculature and responsible for tonus of the entire muscle. This is the core structures which maintain the tone of the muscle. Then you palpate the spinous processes of the L5 and L4, and you inject facet, and you inject lamina. You inject lamina 45 degrees and slightly caudate. You inject here, you inject here. Don't forget inject interspinous and supraspinous ligament. Some authors suggest not to do this because they are very weak and not important. Again, they're important not from stability standpoint, they're important from informational aspect, because they deliver messages about position of the spine, about structure of the muscle, about structure of the tone, and they create reciprocal information to the brain, and this is very important. So interspinous ligament. Again, interspinous ligament should be injected in a caudate direction, touching the bone, supraspinous area in the interspinous. I do not go beyond the L3, because beyond the L3 you may not find spinal processes, and you may end it in the dura, and which can cause spinal headache. Then it's very important to identify PSIS, posterior superior iliac spine. And I use my 3 fingers, my ring finger, middle finger, index finger, and I kind of grab this area. I palpate this PSIS, posterior superior iliac spine. So this is 3, my fingers will be point for identifying an injection. So I put my 3 fingers, so it means that this is superior portion of PSIS, this is medial portion of the PSIS, this is inferior portion of the PSIS, and I mark 1, 2, 3, 4, 5, 6. So this is kind of 6 area which basically correspond A, B, C, D, E points. When it's done, I take a solution, local anesthesia, and I inject and I inject into the edge of the PSIS, and then slowly I dive the needle down, down, down until it reaches SI joint, interosseous ligaments, here, 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 and here. So this is how to inject this whole entire area. It's a very important area because stabilization of the SI joint is very important. You cannot avoid injection of the sacrotuberous area or lateral edge of the sacrum. You palpate lateral edge of the sacrum right here, and you do local anesthesia slightly distally from this line, and the needle must go very, very tangential. You isolate this structure and you inject your needle so you will hit the edge of the sacrum, not above the sacrum, but the edge of the sacrum, where is attachment of the sacrotuberous ligament which control nutation of the sacrum. And the sacrotuberous ligament is continuity of the biceps femoris, which is hamstring muscle. So this is important structure to inject. Again, edge of the sacrum, PSIS, transfer processes of L5 and transfer processes of L4. Then you need to inject ilio-lumbar ligament on ilium. In order to do this, you start your injection on the midline right here, and again you go very, very tangential. You advance needle toward the ilium, and when needle under the skin, you press on the skin and the soft tissue to deepen the needle, so the needle will be actually in front of the ilium. So injection of the ilio-lumbar ligament, very important. You need to see how experienced physicians do this, because this is one of the most important stabilizing ligaments in this area. Iliac crest. Iliac crest, important to inject. First of all, people will ask where to inject iliac crest. Here on the top, where is attachment of the gluteus medius, gluteus maximus, actually gluteus maximus, then distal gluteus medius, or you inject this on the edge of the iliac crest, because edge of the iliac crest is the site of attachment of the quadratus lumborum, number 1, latissimus dorsi, number 2, obliquus abdominis externus, obliquus abdominis internus. All of these muscles attach to the iliac crest from above, on the edge, from above. So a lot of people come to you, for instance, with a flank pain, and you wonder, oh, this is kidney stone, or what it is. Certainly you need to do ultrasound of the kidney or CT scan to rule out problem with the kidney, but in many cases will be symptom related to enthesopathy of the quadratus lumborum, or enthesopathy of the psoas muscle, or enthesopathy of the obliquus abdominis internus, and obliquus abdominis externus. When you rule out visceropathy, like problem with the kidney, you must be able to inject the area of the iliac crest, and you do this very in a tangential way, the same way like I just showed you, you did injection into the sacrum. Tangential area, this is very important. On the other hand, when you see the problem related to abductors of the hip, then you inject strictly perpendicular on the ilium. Perpendicular ilium, initially gluteus medius, and then maximus and gluteus medius, in order to make them strong. I think I cover most of the important portions of these 3 presentations. If I miss something, feel free to ask me questions during open session of questions and answers. I'll be happy to answer and will participate in that. And thank you very much for your attention, and I wish you good health and success.